Thank you very much, Dan, co-moderators, Tom, great to see you, and wonderful organization. Thank you for inviting me again. I've been one of the early adopters of focal therapy. In fact, I remember the AUA approximately about 12 years ago. I had one of my residents when I was at Columbia at the time go up and present on our first 12 patients on focal therapy in a primary setting. And it was a very scary experience for her. She was somewhat anxious and nervous about it, and it received a lot of criticism. And at that time, we weren't using MRIs. We didn't have the biopsy strategies that we have today. And I'm really pleased to see that focal therapy is certainly increasing and becoming widely, more acceptable. And I feel that in my own practice, and I'm going to make this talk very practical and give you my own experience on how I select patients for focal salvage therapy. I think that this modality is here to stay, and many of us are seeing more and more patients who have had radiation therapy in the past, whether it be from external beam radiotherapy, brachytherapy in the past, or SBRT. And at my center, I have nothing to disclose for this talk. I'm now at NYU Winthrop, and we're a major center for cyberknife therapy for SBRT. Right now, we are seeing a significant number of patients in the country that have had a rising PSA, and this is currently the guidelines, the NCCN guidelines for patients who have a persistent rising PSA. And for those patients that are going to be candidates for therapy, for salvage therapy, I strongly urge that you look back at their original tumor, if possible, to determine whether or not they were clinically curable at that time. What was their original T stage? Do they have any metastasis at the time? Some of the patients that underwent radiation therapy may have had a PSA of 50 or Gleason 8 cancer. They never had evaluation of their nodal status, and they may not have been curable at the time. What is their current life expectancy? You're not going to put a patient through salvage therapy. I don't believe you should if their life expectancy is less than 10 years, and you'd like their PSAs to be under 10 at the time. And if they're not a candidate for focal therapy or for local therapy, then you may just want to do a metastatic survey and then determine whether or not they have bone disease and put them on androgen deprivation therapy. In terms of if you believe that a patient is a good candidate for focal therapy, then look at the parameters like PSA doubling time. I don't know why this is in the guidelines, but I've never really gotten a chest x-ray except preoperatively, but I don't do this in my evaluation, a chest x-ray or a chest CT scan. But I do, in most of the patients with a rising PSA now have gone away from bone scan and using an Axeman scan. All the patients undergo a prostate MRI, undergo a biopsy if there's a lesion that can be seen, and then you could also consider a CT scan or bone scan. And if there is a demonstrable disease on ultrasound or biopsy, then the patients have a number of different options. Whether or not you're going to observe that patient is going to be based upon their age, the number of cores that they have on the biopsy, and the aggressiveness of the disease. And classically, the pathologist will not determine a Gleason grade, although many of my pathologists in the area still could grade Gleason after radiation therapy. I don't know if they're doing that in your community. I will also tell you that in my own experience, and I see a lot of primary care doctors or other urologists say you cannot biopsy a patient after radiation therapy for the risk of a fistula or other infections. I have not seen that in my practice, and I biopsied hundreds of patients after radiation therapy. So it is just as safe as it is in the primary setting. And then for patients that are found to have persistent disease, either you're going to consider, and I don't know if anyone in the room is still doing this, a salvage radical prostatectomy, which is considered to be fraught with significant comorbidities, with high urinary incontinence rates, even in the best of hands of about 50%, possible rectal injuries and anywhere from 10 to 15%. And then you've got cryotherapy, which I've been an early adopter of, HIFU or continued radiation therapy like brachytherapy, which I have not been a proponent of. I didn't think on a biological basis it made a lot of sense to give patients more radiation therapy when they already failed. And then if the patients do not have a metastatic survey and they have high-grade disease in the gland, then they would be considered for focal ablation if it's a unilateral disease. Should you consider radical prostatectomy, a salvage radical prostatectomy? And I've looked at many of the studies. I've spoken to my colleagues around the country for years. I debated this with Peter Scardino at the AUA years ago, and it does not seem to be in any studies any significant difference in the overall survival between a salvage cryotherapy or salvage HIFU and a salvage radical prostatectomy. The overall cancer-specific survival, and this is what these patients are most concerned about when they relapse, is whether or not they're going to need hormonal therapy, when they're going to need hormonal therapy, can we delay the use of hormonal therapy with a salvage ablation, and what's going to be their overall survival. In my experience, these patients are alive at 90% with a cancer-specific survival that's quite excellent. The procedure can be repeated if you do a focal therapy. That's one of the other advantages, that you can repeat the procedure, and I have not seen any significant added morbidity in these procedures. And few of the patients, although some of the patients I'll show you will need additional androgen deprivation therapy in the post-salvage setting. Definitely consider age, consider comorbidities. The majority of these patients that undergo focal therapy will not need significant hospitalization. Actually, none of my patients are hospitalized. They're all done in an outpatient setting. They're all done with minimal anesthesia. You can do it with spinal anesthesia in the majority of the patients, or minimal general anesthesia. You can do this with some of these patients on anticoagulation. And again, you want to consider the patients candidates. If they were not candidates for a radical prostatectomy before, they're not going to be a candidate for it now. This is our typical setup at NYU Winthrop, where the patients are in an outpatient setting. They're placed up in a dorsal orthotic position. You probably have seen this. If you're doing either focal therapy with cryo or HIFU, it's pretty much the same thing, and I'd urge you to know how to do transrectal ultrasound. It's all done transperineally. My biopsies that I perform are done transrectally, but the procedures that we perform for focal therapy are done transperineally. This is just another schematic intraoperative photo that I took, I think this was last week, showing the ultrasound. You've got the image there of the ultrasound. You've got your readout on the cryo machine, and I'm using currently a 17-gauge ice rod needle system, which goes through a brachy-style stepper and can go into the prostate, even in fibrotic radiated prostates, and I've had excellent success with this system. After the procedure is done and after a focal therapy is performed, the patients have a catheter in for typically 3 or 4 nights. That's it, and the majority of the patients never need another catheter again. So their quality of life and their return to their regular lifestyle is quite quick. They get an antibiotic for a few days, an alpha blocker for about a month, and then the follow-up is key. And I think the follow-up strategies and things that we're trying to determine the best way to manage these patients and follow these patients to do a PSA and a digital rectal exam every 3 months, at least for the first 2 years, and every 6 months thereafter. And our patients, they all get an IPSS score and a SHIM score, as well as an EPIC score every 3 months. That's mailed to them. And then they get a biopsy and an MRI based upon if their PSAs are rising. We'd like to get an MRI, as mentioned previously in the previous lectures, at least at 1 year to determine if there's any residual disease there. This is a fairly typical patient of mine, 68 years old, who had a rising PSA. The man had external beam radiation therapy 10 years ago. So I think that we're starting to see, at least I am in my own center, many of the patients that were treated with radiation therapy 10, 15 years ago that are now having these slow rising PSAs. I would urge you to get these patients in early. I can't tell you how many times I've seen patients come back. They were told by their radiation oncologist, and I hope there's none in the room that I'm offending, but no, it's not a big deal. Your PSA is rising, but not to worry about it. But a PSA of 2 or 3 after radiation therapy is significantly more concerning than in a patient that had never been treated. So I would look at your PSA doubling time. This man had a PSA doubling time of 2 years. We did an MRI that showed a PIRADS 4 on the left. Why are you texting during my lecture? Jesus Christ. All right. Jesus Christ. All right. I'm sorry. And then what did you say? And the MRI showed a PIRADS 4 on the left. On the left side of the gland, the MRI was clear on the right, and an MRI fusion biopsy in 12 cores demonstrated significant cancer on the left side of the prostate with recurrent cancer in 2 cores. And the biopsies on the right side were negative. We always, despite the MRI showing a lesion, all the patients get bilateral 12-core biopsies as well as a fusion biopsy in that area. The patient elected to undergo a focal salvage cryoablation, and this is during the mid-freeze of the cycle. You can see the extent of the ice ball going down through the left. One of the nice features, if you're interested in preserving sexual function, is doing an intraoperative color Doppler to look at the ipsilateral nerve bundle. I'm not so concerned about the contralateral nerve bundle, but the ipsilateral nerve bundle can clearly preserve sexual function and has been shown well documented, at least in my own series and others, to preserve erectile dysfunction. And then you want to bring the ice ball down and just let it sit on top of the anterior rectal wall. I have not seen in any of the focal cases, these are all focal salvage cases, to have any fistula or any bowel dysfunction. This is what the MRI looks like 12 months after focal salvage cryo, so there's no enhancement. It's still texting over here. And no enhancement there, and this again showing an ablation. His PSA remarkably is down to 0.4, and a repeat biopsy did not show any evidence of cancer. Shim score is quite excellent at 24. Again, so this is, stop? Oh, wow. Okay, I'll sum up then. This is our basically our 100 case, 96 patients in the last 96 patients that we had. Urinary incontinence, this is new onset, is fairly low. It's much lower than a radical prostatectomy series. Some of the patients, 4% needed a residual catheter, but there was no fistula, no hospitalizations, no infections or strictures, was very low. Worsening Shim score at a year was 11%. The majority of these patients, though, are using some form of PD-5 inhibitor or intracavernosal injection. This is our quality of life, showing that sexual function will improve over time. And again, I just wanted to, maybe I should just end here and show you that, again, the overall survival of focal salvage therapy, this is the 8-year experience, is excellent, and the freedom from hormonal therapy is quite good. So projected at 8 years, it's about 70% of these patients are not going to need androgen deprivation therapy. I think that's big. I think that's really important for the overall quality of life for these patients. So I think there's great technological improvements in this. Some thoughts, we're hearing a lot more about the role of genomics and genetics in its infancy, but clearly needs further investigation for focal therapy. And I want to thank again the organizers for their time and for attention. Thank you very much.
Thank you very much. Thank you, Dr. Katz.